Hi everyone, I'm Rafi Picciotto. I'm leading the drug delivery programs at Insightec. I'd like to take this opportunity to thank the FAST Foundation for their sustained support of focused ultrasound-based therapies and for the invitation. I want to talk about a medical device designed to deliver drugs to the CNS. There is really no need to detail to this audience the importance of the blood-brain barrier and its function as it poses, and also the fact that it poses a challenge to drug delivery to the CNS. So clearly a device designed to deliver drugs to the CNS would need to facilitate a safe and reversible BBB opening. Being a non-invasive device would be an advantage. And in some cases, repeated procedures, repeated BBB opening would be needed to support a particular drug administration schedule. Focal therapy may also offer a significant advantage depending on the drug and the indication at hand. Ultimately, a device like that would deliver the desired amount of drug to the desired location uniformly and provide means to confirm that the job indeed was done. One could argue that the device should also confirm the delivery of a specific amount of drug into the target location to assure the desired therapy. So we'll talk about these different attributes. Drug delivery program in Insightec started 5 or 6 years ago with pioneering work at Sunnybrook in Canada in late 2015, and today with a growing network of research sites with many clinical protocol and hundreds of procedures. The program is growing and in fact accelerating. So the first challenge I would like to talk about is the need to treat large tissue volumes. And there is no need in this audience to describe the dire situation of GBM patients in general and the fact that the remnant tumor infiltrates at some point very quickly into the neighboring tissue despite radiotherapy and chemotherapies, resulting in recurrent GBM, which infiltrates to vast areas of the CNS. We do BBB opening by using microbubbles and partly because of some limitations on the amount of microbubbles that one can deliver to a person, there is a particular time window for which one needs to complete the procedure, which in essence says that one needs such a drug delivery device to be able to open the BBB in large tissue fast. So the rates are, let's say, 10 to 100 cc's per hour. This is what would be required. On the other end of the scale are needs to treat very precisely in the CNS, as for example in neurodegenerative disease cases where particular brain structures need to be treated. And because neighboring brain structures may be eloquent, and depending on the drug used, this procedure may be very important. And of course, focused ultrasound is geared up for such a task. Small F-number transducers can generate millimeter-sized spots, and adequate correction of the aberrations of the skull allows for maintaining such tight spots inside the CNS to facilitate precise drug delivery as indicated in these examples here. Another challenge we face, again in GBM patients, is that we don't get to choose where the treatment region is. In often cases, it is right up next to the skull, which highlights the importance of skull aberration corrections to, again, maintain focal therapy and ensuring treatment of the desired tissue region. Staying in neuro-oncology, but switching to brain metastases, here the volume of a particular tumor may be smaller, but there are multiple foci that need to be treated. So in that case, it is desirable to switch quickly between treating of different brain mets, and even better to parallelize the treatment and treat some of them at once. This poses a technical question related to fast transducer or phased array transducer construction, which goes by the name of hotspots, which amounts to concentration of sound waves in a place not targeted, not desired, and not planned for. It comes about because of a regular arrangement of the phased array elements in the transducer, and also called grating lobes. This can be mitigated by more advanced transducer designs, as shown on the right here, allowing for large electronic steering of the focal spot, maintaining its tightness and avoiding any hotspots. And this would allow quick steering between different foci and treatment of numerous foci, even in parallel. So I'm going to switch to talk about the uniformity of drug delivery. What is shown here is an overlay, a color map of bubble activity, which is shown on the left to be inhomogeneous within a large target. This can come about because of local changes in the tissue, in the vasculature, or what have you, but at the end of the day, there is more bubble activity depicted in red on the left as compared to the blue on the right. And even if you control the fast parameters to dictate a particular level of bubble activity, it will provide for that level on average, but still the resulting bubble activity will be inhomogeneous in space. This can be addressed by a more sophisticated controlling mechanism where the fast parameters are controlled locally to assure a uniform bubble activity map, as shown on the right. And this is an example of preclinical work in the pig model, where again on the left you see a controller controlling the entire target on average, as opposed to a controller on the right, which controls the bubble activity locally. And this can be extended to large targets to support drug delivery for large volumes of tissue, such as needed in GBM patients. Let me switch to talk about MRI and its role in BBB procedures. So we typically take T2 star weighted images during the sonication to look for any hypointensities developing during the procedure. And often we do see such hypointensities. In the scientific literature, they were shown to be associated with petechia, so ultra small, say 10 or 100 micron sized hemorrhages occurring in the tissue. We see these hypointensities actually fading away when following up patients, and I should emphasize that we never saw adverse events in our studies, regardless of whether the patients did show T2 star hypointensities or not. So at the moment, we're not sure what these hypointensities are indicative of and whether they are really should be treated as a safety signal or some other tissue response. Another way the MRI comes in very handy is to assess the outcome of a BBB treatment. And what I'm showing here is two one-weighted images after gadolinium contrast before and after the procedure. And we use such images, the difference between such images, to grade the procedure or grade the BBB opening. And you can see from left to right examples of lower to higher grades of BBB opening procedures. This is, of course, quantifying the delivery of gadolinium to the CNS and not of the drug. One can think of drug gadolinium complexes to try to relate that to drug concentration. One can think of more sophisticated MR techniques, such as MR spectroscopy, to look at vehicles, or maybe at the drug itself, or maybe try to relate MR spectroscopy to metabolism-induced responses or functional MRI if the drug induces a hemodynamic response. So I talked about all these different attributes of a device designed to deliver drugs to the CNS. And with that, I would like to thank you for your attention.